1.
All right, everybody, good morning. Welcome you to our STED Talk, Spine Technology Education, and the D is multidimensional. It's today maybe deformity also, but it's usually discussion, discovery, discourse. And we have a fantastic guest lecturer today, Dr. Zuckerman from Vanderbilt, a neurosurgical colleague. I'll introduce him in greater detail later. And he's chosen a really cool title, which vexes all of us, Coronal Alignment or Misalignment, and how to restore that. And I'll introduce Dr. Zuckerman later, but he's joining us from Vanderbilt, and he's already, for his young years, a very experienced and extremely well-decorated and recognized colleague. Good morning, Dr. Zuckerman. Can we hear you?
Morning. I can hear you okay. Can you hear me?
Loud and clear. Yes, loud and clear. So today is September 4th, and this is again the fall season is about to start, and this is a great topic today. And as always, we have our wonderful fellows who have a couple of cases to run by you. And I think we have 5 cases, so we'll start running. So we'll start from left to right. And coming up, Dr. Nick Minisali is here from New Jersey/Philadelphia, and he has a case with some deformity aspects.
Perfect. Thank you, Dr. Chapman. So no disclosures relevant to this talk. So this case is a mid-70s-year-old female who presented with left lower extremity pain, numbness, as well as a foot drop. She had a prior surgical history of an L4-5 transforaminal lumbar interbody fusion, and then L5-S1 TLIF as well at an outside institution. As far as past medical history, fairly healthy overall, does have irritable bowel syndrome and hyperlipidemia. Socially, she's not a smoker, does not use alcohol, ambulates with a cane, and lives with her husband at home. On physical exam, she does have a Trendelenburg gait on the left, 3 out of 5 left EHL, and 4 out of 5 left ankle dorsiflexion, but no other overt weakness. So here are upright scoli films. Shows a 29-degree level scoliosis from T11 to L4. It's degenerative. Her SVA is negative 3.7. PI was 57.9, and lumbar lordosis is 51.9. On flex X films of the lumbar spine, there is some retrolisthesis of L2-3, so some instability there, and then some questionable motion at L4-5. So a CT was obtained. Let's see if it'll work for us.
Contrasted CT, yeah.
Yes, and so there's an obvious non-union at the L5-S1 fusion with some loosening of screws at S1, and then the L4-5 is kind of unclear, but there's no obvious neural compression there. And then again, that coronal deformity is seen, especially on the coronal images there. So in summary, mid-70s, relatively healthy female with a prior lumbar fusion, L5-S1 non-union now, degenerative coronal deformity, and foot drop. Only other info I could add would be that her CT Hounsfield units at L1 were in the 120s, so kind of above that threshold for osteoporosis. A prior DEXA in 2021 had her at negative 2.1, so she's osteopenic but not overtly osteoporotic.
So Dr. Zuckerman, good morning again. Thank you for joining us. So this is something that is omnipresent in our clinics nowadays. This is a lady with an academic background. She's very well kept. She's just lost, I forgot what it was, 3-4 inches body height. Her rib cage is abutting her pelvis now. She and her husband have had always a friendly rivalry, and she's upset now because she's kind of a little bit shorter than him. She has this multi-level degenerative disc disease. She has no arthropathies, so her hands, her shoulders, her hips, knees are okay. Her feet are okay, but she's just this collapsing lumbar spine. And then a colleague decided to do an L4 to S1 fusion. I don't know whether it was for a fractional fusion or whatever, and now she has a non-union, and she's actually quite disabled. She has an L5 radiculopathy. So My first question is, what's going on? I mean, is this here in the Pacific Northwest? Are the people eating the wrong foods, or is there something else going on that has complex collagen pathology, inflammatory disease prospects?
Yeah, great question. Yeah, patients with a previous 4-to-1 fusion having problems is something well known to all of us and a vexing problem. And I would say, come to the South. It's even worse in the South. Pacific Northwest, everyone's healthy. Everyone hikes and kayaks. In the South, it's a little more challenging sometimes. But yeah, I think this is an interesting case. I didn't. It sounds like the main problem here is a foot drop and an L5 radiculopathy. We all see the vacuum disc and lateral listhesis and the mild scoliosis in the upper lumbar spine, but does she have a ton of back pain, or is it
Yeah.
mostly the foot drop and left leg?
I can emphatically say yes, a lot of back pain. She's very stoic. Again, she has an academic background. She used to be extremely active, and she's basically resorted more and more to limping around with a cane, which I hate. They fall forwards and to the side usually. That's not her. She's really well kept. She takes pride in her appearance and everything.
Yeah, so I would just have an honest conversation with her and talk to her about probably the number one problem, which is her left foot drop and L5 radiculopathy, probably because of the non-union of 5-1. And that's a much smaller surgery to fix, maybe with a revision decompression and maybe something anterior to try and get a solid fusion and arthrodesis there, versus the bigger option, which is some kind of variant of a T10 to pelvis that would address some of her back pain. But she's overall pretty well aligned. She's a little negative in the sagittal plane and slightly coronally to the right. So I don't see anything forcing our hand here for the T10 to pelvis or deformity surgery. But if she's collapsing, if she's having a ton of pain, and she's interested in a much longer operation that'll take a full year to recover from, a week in the hospital, et cetera, then I think we could definitely do that. But that's the conversation I'd have with her in the two options.
No, that's a bingo. Yeah. We usually always get to know our patients, so we spend a fair bit of time with them. They don't get booked for surgery right away unless there's something catastrophic or structurally neurologically massive. So she did participate in our prehab program. She had a fair bit of time to think about it. What do we do and why?
So we went with removal of that posterior hard rail L4 to S1, removal of the L5 S1 cage from the posterior approach, revision laminectomy from T12 to S1, and then we did intradiscal osteotomies at L1-2, L2-3, L3-4, and L5 S1 with bilateral cages at 5-1, and then unilateral cages at the other levels to maintain and restore that coronal balance, and then a posterior quad rod construct T8 to pelvis.
So as he's scrolling through the coronal, this patient, free of any form of influentiation, I think with a very diligent discussion of pros and cons, it chose the bigger option. There was no coercion whatsoever. We talked about just a limited procedure, just as what you had outlined. And she felt crippled from her back. So we chose the all-out option so far, and we decided to rebalance her spine. If you stop that we did these intradiscal osteotomies. So when you have these eccentrically collapsed spines, which will obviously, hopefully, or which you will address in your talk, how do you realign the spine when you have these kind of catawampously tilted vertebrae that are subluxing laterally and are tilted offset?
Yeah, so first of all, great result. X-rays look great. I think PI was 57, so that's kind of a Rucheli 3, so it looks like she's got a very harmonious back now. The lumbar apex is around the L4 or 3-4 disc, and it looks great. And coronally, I think that's the supine CT X-ray you have there, but standing X-rays, I'm sure she looks good. I'd be worrying about throwing this patient off to the right side, but it looks like she's very well coronally balanced. But to answer your questions, and it's really just good PCO work, good carpentry. I think if you do a good PCO, and if you're doing a TLIF or intradiscal osteotomy, which is from probably just a more aggressive form of a good TLIF, and bilateral disc access, which I find very helpful. If you do a good PCO and good disc access and good carpentry, you can really loosen up the back, especially at those upper lumbar segments. Lower lumbar, the fractional curve, which we'll get into, is a lot more challenging and stiff, and requires a lot more carpentry, a lot more work, especially with the sensitive L5, L4 nerves. But this looks great.
So I sensed before the non-union of 5-1, this is a very, very common problem. And again, here I chose to go backwards, but I sensed from your response before you would do an anterior and then posterior surgery, or posterior and then anterior surgery. How would you handle that?
Yeah, I think it's an option if, the front back is an option for a fused spine. So that I don't think we'd have to do that here. But I think if you didn't want to dig through the scar tissue, which you did, and it seems like a great job to get bilateral cages in, any lift is an easier option and less technically challenging. And with the loose screws, I think you would probably just get a medium cage in there that would fit. So you wouldn't need to do a front back. But I think an A-lift to plug the front and then going posterior would have been a good option here. But this is probably less stages, and she probably got out of the hospital faster.
Yeah, the 1 week hospital stay is prophetic. She was a little bit slower in getting going than anybody else. Thank you, Nick. In the interest of time, we'll move ahead rather rapidly, and we'll pick up on the theme that you just mentioned. Dr. Julius Gerstmeier is our research fellow from Germany. He's from Bochum, from northern Germany, and he's going to finish his year here in the near future, and we'll miss him already. He's done a lot of great work, and he has a case that I think addresses what Dr. Zuckerman just talked about. Julius.
Good morning, everybody. So I'll be presenting a around 50-year-old male that has been around our clinic for some time. He has a lower back pain on the right side of radiculopathy. He also had a disc herniation, so he received prior to his presentation a laminectomy and sequestrectomy at L2-3. He has a rather disabling ODI score, but no further disabilities in his neuro exam. So this is his standing films. This is the last X-ray we obtained. It's a worsening condition over time. His scoliosis is between L1 and L5 is measured at around 51 degrees. And he also has a left foot listhesis at L1-2 and 2-3, in addition to a right-worded listhesis at L3-4 and 4-5.
And if you can go back one, Dr. Zuckerman, a question about your standing scoliosis film. So we still don't have an EOS machine. I'm not sure that our system can ever make that operational from a fiscal perspective, which is the overarching concern these days, it seems. But a technical question about upright X-rays, which is so key to all of our measurements. Do you get a dynamic upright film where you have a patient stand for an AP and then do a recumbent one, or like a scout CT for comparison to look at the dynamic collapsibility of the spine? And do you tell your patients when they're standing up to kind of pull themselves up? Or what do you do with their arms, and what do you tell them to do so that the lateral is a lateral and not a pull-up film?
Yeah, so first of all, you're not alone with the EOS situation. I've had about 9 meetings about trying to get EOS here, so it's very frustrating. So I feel you there. But no, how we get these X-rays is really important. I'll do supine films. Bending films are hard for some of the techs to do. It's very effort dependent. So supine films, and I'll get a dedicated supine X-ray. You can certainly use the CT Scout, but I think a dedicated supine film is just a little higher quality. And then you're right. I mean, think about how much planning and thought we give off of one X-ray. We don't know if that was a bad day for the patient and they couldn't stand, it was 4 p.m., or was it a 8 a.m. X-ray when they stand great. And we're doing all this planning and a life-changing surgery based on one X-ray. So I'll get a lot of serial X-rays to see how things change over time. But I just tell them to stand as if you would in normal, comfortable posture, not like upright like a military position, but not slouched at the end of the day, sort of an average posture to try and get some idea of what their day-to-day is like. But I think there's a lot of variability that we probably don't appreciate in these one single snapshot X-rays, which speaks to seeing people a lot of different times, like you mentioned.
Great points, thank you. Okay, Yulia, sorry to interrupt you.
No worries. I just wanted to share these CT scans with you, so we obtained from both lumbar and thoracic spine for planning.
And bone density was?
That wasn't of an issue.
Not an issue, okay. Scott, do you use Hounsfield units more routinely now, or do you still stay with DEXA scans?
I'll do both. Hounsfield units are so easy to measure, especially when choosing your UIV, and especially if the DEXA is good, but I know for sure the bone quality is poor, I'll try and push them to our rheumatologist for bone optimization.
So any thoughts? I mean, so this
Yeah.
looks,
So in the interest of time, I'll skip the thoracic one. So yeah, let's open the
Yeah.
discussion.
Yeah, great case. So degenerative scoliosis, mainly a thoracolumbar/lumbar curve. Can you go back to the x-rays real quick?
Yeah.
So it's got you can often predict where the radiculopathy is just from the x-ray. I think neurosurgery residents, especially in our residents, we're always quick to jump to the MRI. But the concavity of the fractional curve here is on the right side. I usually flip the x-ray, so left is left, right is right. But the right side is collapsed from 4 to 1. So no surprise he has a right-sided radiculopathy. And he's not really symptomatic from the concavity of the major curve on the left side. So for me, given his radiculopathy, how arthritic his L4, 5, and 5-1 is, you're going to have to go to the pelvis. Though in a 40-50s ADIS or degen scoli, I think about trying to stop at L3 or L4. I think you have to go to the pelvis here. And then the spine is not fused, so it's flexible. So I'd be interested in what his supine films look like, but I bet we could get away here with a T9 or T10 to pelvis, multi-level PCOs, good strong screws with reduction screws or towers, and try and bring the spine to the rod here. He looks pretty well aligned in the sagittal plane, although his head is over his hips, but looks like he's compensating with the retroverted pelvis. So give him a little more lordosis down low and correct the scoliosis and make sure that we don't throw him off to one side with our intraop film. So I'm thinking potentially a kickstand rod. If we can't correct the major curve, maybe on the left side, but you may also need one on the right side if you can't correct the fractional curve.
and do far lateral or anterior oblique fusions kind of weigh into your decision making? Is this something in your repertoire that you routinely would use in a deformity like this?
Yeah, I don't use O-lifts, or I'll do O-lifts. I don't do transpsoas. But I mainly do that for degenerative issues like the L4-5 spondy or L3-4 is my go-to. I don't really use it in deformity though.
Okay. All right,
Should we
Julius.
reveal?
Let's go reveal.
Okay, so this is his construct. We opted in for a long construct to the pelvis and did 2 lateral interbody fusions, transpsoas approach.
And what was done for the, so Dr. Zuckerman pointed out 4 to 1 at the fractional curve with radiculopathy. Were they decompressed? Was there something done to augment a fusion potential in those patients, in those segments?
No, at this moment, not. Oh, he did much better after the surgery. And
So it was done minimally invasively and it was staged.
it was a stage procedure.
So it wasn't done all. I did lateral and then we did posterior. And the plan was to bring him back and do an ALIF, but he was doing so well, he kind of kept putting it off and kept putting it off and kept putting it off.
Yeah, his radiculopathy got better just with a little bit of fractional curve correction.
Yes,
definitely.
Yeah, like went hiking like 2 months later.
Yeah, I hear you. Hard to take someone to the operating room after when they're doing so well. So
Yeah.
Fuse the L4 to S1 segment. So you said this is minimally invasive. I see the MIS rods. Was there anything done to get a fusion L4 to S1?
Yeah, I mean, we burnt out the facet joint, but again, the plan was to bring him back for an ALIF.
Yeah. Are there S1 screws?
There's not, because there was not enough room.
Wow.
So,
Okay.
yeah, I see the iliac screws are a little high. But yeah, I mean, if you didn't do a lamia 4-5 or 5-1, so there's a lot of bone there, but something in the posterior lateral gutters, good decortication, maybe at a later time or something. But
I would fuse them from the front.
what's that?
I would put cages in from the front.
Yeah, so he
That was kind of the plan.
he did lay off the procedure, but then he after his initial clinical or the residue of his symptoms, they came back. They had a little bit of lower back pain and the radiculopathy kicked back in. So about 2 years later, he received an ALIF procedure, and this is just the latest follow-up images. We see a fracture of the screw on the right side, but he doesn't have any symptoms anymore. So we opted in for observing that.
So he finally came back for his ALIF.
Yeah, like 2 years after the index procedure.
Yeah. I mean, I think for me, getting for the pelvis or the sacrum fuse is always the most challenging thing when you're doing MIS. So.
yeah, I mean, the benefit of MIS, I'm sure he left the hospital very quick, much quicker than open and looked great. But yeah, those starting iliacs lower, I found definitely helps, gives you a lot more real estate for that good fixation in S1. But yeah, definitely the most challenging level to fuse, probably in the whole spine, next to maybe the OC junction.
Yeah, no, I think these are great principles, and there's such an allure to do these minimally invasively, and this again shows the enormous biomechanical forces at L4 to S1, and again, what to do with the pelvic joint and how to fix those properly. Were those cannulated screws?
Yes.
Yeah, so the cannulated screws is one of those things that the companies don't tell us enough. They're actually always mechanically weaker than solid screws. They do have that small technical problem. I have a couple of patients floating around that I've inherited from other practices where there's some sheared off guide wires in the lesser pelvis that I'm not going to go to, and we're just watching them. But I don't know what to do about those. To get those out would be horrible, and they've been just left in there. So I'm not a fan of these cannulated screws for the pelvis. I know they're very en vogue, and they allow for elegant placement, relatively controlled, but I don't know. What do you do for iliac fixation?
Yeah, I do usually S2AI screws, minimum 8580. If I can get a 90 or 100 in there, I'll be happy with that. But they're not cannulated. I just, for gear shift, make sure I'm right on the notch. I like these screws to be right on the sciatic buttress because it's some of the strongest bone in the body, and it can rest there because the failure mechanism is toggling rather than a pullout or anything. So if it can rest in the sciatic notch, and then we just make sure when the teardrop, I have a good base, put in 80, 90, or 100. But trying to get them low, I think, is a change in my practice I've made relatively recently.
And no formal SI joint fusions, right? If you do S2AI, you hope that there's kind of a fibrous ankylosis that's stable.
Yeah, if someone doesn't have a great reason to have 4 rods, then 4 points of fixation in their pelvis, I try and stick with 2 because I'm realizing that we're not curing any one of their spinal problems, and we may need to come back. I worry if you put 4 in, you lose real estate. But if I have a good reason for it, bad osteoporosis, L5 PSO, or really degenerated SI joints, then I'll go ahead and do it because I do think it's better to do it now than at 6 months when they may fail.
And just reminiscing on Dr. Gerstmeyer's presentation, staging these surgeries, when you do these anterior-posterior surgeries, in order to not have patients run off with a nice posterior result, do you do the ALIF first and then do the posterior surgery in the same hospital stay, or do you get them in and out to kind of maximize the reimbursement potential? What's your sequence to get these maximally done?
Yeah, usually a Monday and a Wednesday. Monday we'll do the ALIF, oftentimes with 1 screw in the lower body or one body. And so it's not the most stable situation. So I keep them in bed and then take them back just 2 days later on Wednesday for posterior.
Got it. Yeah, that makes sense. Seamless switch. Thank you, Dr. Gerstmeyer. We're going to Dr. Mark Kramer from the wonderful other UW, the University of Wisconsin, neurosurgical colleague, and here to show something that we have an increasing number of, and that is MIS fusion surgeries in various choice levels. Dr. Kramer.
Excellent. All right, so this is a case of a 50-year-old gentleman. He presented with quite severe back pain. This is his primary complaint. In regard to his symptoms, pain was much worse with extension of his back. He also was complaining of some intermittent saddle numbness. He didn't have any frank cauda-equina-like symptoms when he presented. He had already undergone multiple months of physical therapy, had already tried several injections with no significant improvement. He had no significant past medical history, and here's his past surgical history. You can see he's had a 2 to 5 lateral interbody fusion. It was performed anterior to psoas with percutaneous instrumentation placed posteriorly. There was one take back after that procedure for a failure of 1 screw. This was done about 4 or 5 years prior to his presentation to us. You can see his physical exam here. He's a nice Pacific Northwest body habitus, BMI 25, normal bowel bladder function. He had some mild weakness in his lower extremities, as you can see here, knee flexor, EHL, and some slight diminished sensation in his lower limbs symmetrically. So this is the MRI that he comes in with, and I'll just play through this. So you can see he's got, not well shown here, it's a dextroconvex curve. It's kind of centered around L3. And he's got some foraminal stenosis at L1-2. He's also got some lateral recess stenosis at 5S1.
But the central spinal canal is patent. He's a generally healthy person, so there's no neural, and here's the real problem.
Yeah, so, and I'll put up his parameters here. So his C7 plumb line, central sacral vertical line, you can see it's fairly balanced, about 1 centimeter to the left. He's got a 42-degree curve, again, measuring from 11 to 5. And then in terms of his sagittal balance, he's a little positive, plus 4 centimeters. So at this point, he was seen by us, and we recommended CT imaging with a myelogram. And you can see on the coronal, again, patent central canal with that curvature already described.
So we sadly did not have the original films. This patient actually, just to identify the problems, I think he had 3 or 4 surgeries previously over a stretch of like 5 to 7 years in outside practice. And I think he started with an L3 to 5 fusion, and then the surgeon added the L2-3 fusion to that, then had problems with that. There's a CSF leak with a neurologic problem involved in that L2-3 add-on. And the patient is basically, this is so he has a little bit of ambiguous L5S1 vertebra. You can see that oversized transverse process. So a little bit of a Bertolotti phenomenon there. But the patient was completely disabled from his series of back surgeries. And he was basically told, this is all we can do, and given up. And he actually, this is an executive for a larger, well-known software company. This is a life-changing thing for him. He basically quit his job at some point in time, just being crippled. This is a physically very active, non-drug-seeking person who's gone through all sorts of pharmacotherapies. I think he never went to a ketamine clinic, but he went through that and finally got rid of that. But if you go back to the overall X-ray, this is something I see a lot of, and I looked at my clinic today. I'll see several patients of. They have these selective fusions done L3 to 5, usually because they're very inviting for outpatient surgery centers. And whether they're indicated or not is another question, but especially when there's a deformity present, they sometimes accentuate the curve. These are done from a left-sided approach, these far lateral surgeries. Is that something you're seeing also, these kind of ill-begotten, less invasive surgeries where there's no attempts made or no effective ways to realign the spine?
Yeah, this can be really tough. I mean, the saving grace here is you have 5-1 open, so I think that's a good option for how to treat this. But yeah, I mean, this is a brutal problem. You got to ask yourself, why did this patient have some kind of fusion surgery in his 40s or maybe even 30s if this was a long course for him? But brutal for this young guy, very brutal. Bad problem.
So, Rod, you're a far lateral surgery champion, and you've done these for well over a decade. Choice of side, left versus right, so laterality relative to a curve, does it matter? I know you're a proponent of left side surgeries. This was actually done here. Did that make matters worse?
I think, this is a case where if we would have had the original films,
we don't have it outside practice.
No, I know. It's, I think it looks like he's got a little bit of the the apex looks like it's like a lot higher, but I usually go from the left, and, I do think that there is a role for the, lateral approach. I just think I'm pretty selective. I'm not sure I would have ended it on this case where they ended it. So I think that's probably, looks like he's got still a fractional curve left above, so it's tough. I mean,
yeah, and this,
they're not easy.
I think about the intersection between degenerative deformity. It's such a continuum. The first surgery, maybe you don't need to think about alignment or anything as much. You're just decompressing something. But then as you keep adding on and on, it becomes harder to treat the alignment and the deformity. So for some reason, we ignore it more and just say, all right, we're going to treat the neurologic issue. And then you end up ignoring it 5 surgeries later, and you're left with a really bad problem here.
So solutions now. So This man, somehow, he had given up actually, and then some friend of his said, come over here. So he showed up in our clinic and said, any thoughts? Just like what Dr. Kramer put on, anything that you can do to help me here would be appreciated. And he had actually resigned that this is going to be his life. So how do we fix this now?
Yeah, so he's fused, which is not ideal in this position. But as I said, taking advantage of that 5-1 disc can do a lot for us, both sagittally, because he looks pretty flat from 1 to 5 in his fusion, but also coronally, because you got probably guess a 15, 20 degree fractional curve from 5-1. So A-lift is powerful, but sometimes I've seen with A-lift is not to get too aggressive, but you can get some stretch neuropraxias and real neurologic deficits after that. So I may go from the back first, just to clean out everything, do a big PCO, just make sure the 5 and 1 nerve roots are completely free, and then maybe go back in the front to get some good sagittal correction, because it's, you can get good lordosis with a big T-lift, and that's an option too. If you can get a 14, 15 height cage with some good lordosis. But if you clean everything out in the back, then do a well-positioned A-lift from the front, maybe with personalized interbody cages, which are a nice addition to what we do, trying to realign the fractional curve, and then you have to go up to around T9 or T10. But I worry coronally that fractional curve is going to be really stiff, especially with the fusion above. The L1-2 apex there is going to be relatively easy to correct. So if you correct the apex at L1-2, but you don't correct the fractional curve, this patient's going to be thrown off all the way to the right side. So that's kind of how I would process it. With dealer's choice, whether a good deformity T-lift at the bottom or some posterior releases, and then an A-lift, and then go in the back again, I think are both options.
Dr. Kramer, you come from a major center in the U.S., Madison, Wisconsin. What had you been exposed to in Madison?
Yeah, I think a lot of our staff would have ended up going from the front at 5-1, and then backed it up, kind of as described, revision of hardware, and then try to correct that curve at the top at 1-2 and 12-1, probably likely with T-lifts.
What was his PI again?
I don't have his PI listed here.
Looks medium, maybe a little on a 50, 60, something like that. But that's something that's important too, because how much you want to get at 5-1. And if it's a high PI, you may even have to do a 3-column osteotomy at L4 to get more lordosis down there.
Yeah, I'm with you from what I sensed earlier. If there's a solid fusion in these old fusion areas, I try not to do a PSO anymore. I used to do those fairly routinely. I do them sometimes, but I try to avoid it. I use that as a fixed block and try to tilt around any open segments. So let's see what we did here. Mark, how we resolved this?
Sure. So this is our post-operative CT. I'll start with the coronal here first. You can see we approach everything from the back, and we ended up doing a nice release at 5S1, put an asymmetric cage at that on that right side. You can see right here. And then
nice bone graft on the left side too.
Yeah, I'm with you. I like to do these bilaterally and then push a lot of bone graft towards the cage from the opposite side to get an impacted also, so that this is going to heal and remodel very rapidly.
And then at the top of the curve, we did nice releases as well with intradiscal osteotomies at 12-1 and L1-2, and then fused from, it was T10 all the way down to the pelvis. And then the sagittal correction was also very nice. And then just follow up on that, this is the post-operative x-rays. So this was actually just a few days ago, we saw this guy in clinic. He's doing extremely well. He's very happy. And his leg strength is improved, and he's actually doing very well.
Yeah, gave him his life back. Yeah, looks great.
As a fusion surgeon, this is as nice a result as one can ever hope for. It's like an advertisement case. I felt bad for this man because, again, he literally had given up his life and his executive career because of his back, and this is a completely new beginning for him. I don't want to expand too much on that, but even when we see these massive multi-level fusions, this man is extremely functional again, and just off all medications, and just returning to life. So I always want to caution everybody that fusions are something biomechanically extremely consequential, and I try to avoid fusions wherever possible in favor of decompressions or motion preserving techniques, but this was actually very gratifying to see, and I think we are aligned in our thought of realignment being so important. That was a very weak pun, I apologize, but getting the spine realigned into the same geometric sphere and trying to rebalance it is a really big deal, and having a solid fusion. So are you, I heard you talk about kickstand rods and everything like that. Are you a multi-rod person for adult deformity surgeries on a pretty routine basis?
Yeah, I think kickstand rod is a great technique, and we'll get into it a little later. And it's not nearly as it's not really. We do much harder things in the spine, and it's a really nice tool. And I like using multi rods, but I don't. Whenever I use multiple rods, I always tell my residents this does not take the place of good carpentry. And we put the rods down. It's the last thing we do, because you got to get a ton of bone graft down before, or else you're going to be back with a pseudoarthrosis in 2, 3, 4 years. But I think it just helps delay, that gives the patient more time to fuse, and it's relatively easy to do. But it's not a band-aid for suboptimal carpentry, and you got to think about the bone, laying down good bone first.
Rod, hypothetically, far lateral surgeries, especially in the upper lumbar spine, would that have been an option for you here, coming from the left side?
I mean, I think you did the right thing. I think 5-1, you did a really nice coronal correction by doing the unilateral cage, so.
Yeah, Dr. Hart always, and we just had our deformity course here with Stephen Lewis, Dr. Hart here, and a number of others. Amir Abdul-Jabbar, our partner, did the co-chairing. They did emphasize how critical it is that we somehow use the lower lumbar spine between, ideally, L5S1, L4-5 to rebalance the spine, and I'm sure you'll talk about that also, that lordosis and coronal balance can be heavily influenced in a disproportionate fashion almost in these lower segments. Any thoughts on that, Dr. Zuckerman?
Yeah, totally agree. 4-to-1 is really where the money is, and it's the most challenging part. But this is salvage surgery for this guy, and you gave him his life back. So it's a challenging thing. And I would just say, I think the market was, I kind of like to know the PI. I'm sure you guys knew the PI before. I kind of like to know the PI on almost everything, even a 1 or 2 level fusion.
I'll show Dr. Kramer, who will have the pleasure of going to clinic with me. They're actually all recorded in the bottom of our imaging section. Our radiologists actually now record them also. So note taking, our fellows will have the proper alignment figures there in the future. They're actually recorded in our chart. So my apologies. Next is Dr. Hogshead from the wonderful state of Texas. So thank you, Dr. Kramer, but nice presentation. Dr. Hogshead has another version of a more recent salvage surgery. Again, he comes from Fort Worth, Texas, and glad to have you here in the Pacific Northwest.
Good morning, thank you. Yeah, this is a case of more traumatic coronal imbalance and instability. A 83-year-old female, she had a ground level fall with severe back and left leg pain that was debilitating. It was a mechanical fall. She was actually down for prolonged time at a retirement center for at least 8 hours, they counted. She's got a history of extensive comorbidities, sick sinus syndrome, status post cardiac pacemaker that's in place, AFib on Eliquis, chronic kidney disease, rheumatoid arthritis. She does have a chronic pre-existing flexible torticollis of her neck, as well as 3 previous spine surgeries, kind of continuing the discussion of haphazard MIS procedures. She initially had a L4-S1 posterior spinal fusion in 2010, and then subsequently adjacent disease breakdown that was treated with L2, L3 lateral interbody MIS fusion, and then a L1, L2 lateral interbody MIS fusion from the contralateral side, as well as look like MIS passage of rods from L1 to L3, not connected to her previous L4-S1 fusion. That's just a coronal snapshot from her CT that we'll look at later. She ambulates with a walker at baseline, irrelevant social history. Her exam was limited by significant left leg and back pain. You can see her motor exam there. No bowel or bladder symptoms. She was hypotensive upon arrival, probably with an acute kidney injury just from her not being hydrated and down for some time, and probably some minor injury from rhabdo. Her echocardiogram was stable. She did have a pacemaker in place, and so cardiac clearance was obtained for her. These are her coronal and sagittal CT scans of the lumbar spine without contrast here.
So this patient had a series of MIS surgeries, and this is, again, I sound like an apostle speaking against MIS surgeries, but I see this a fair bit also. They've received several MIS surgeries. They have incisions all over their body, and they have one elegant MIS surgery at one or two segments, and then something else gets attached to it that's a little bit less elegant, and then something else gets attached to it, and at that point in time, things get a little bit desperate. So she had two discontinuous implant systems, basically, I should say, between L1 and L3, and then L4 to S1, right, Cameron?
That's correct.
And so there's no direct continuity outside of a far lateral procedure that had been done at 3-4. And then the patient fell and basically sheared across 3-4, and she had agonizing back pain. This is a mentally very spry patient. She has, again, torticollis. She's kind of a character. She has a reasonable low dose of alcohol, which she has. She lives in a very nice retirement facility. Again, mentally extremely sharp, fraught with multiple medical problems. You see the T12 older compression fracture above, so bone metabolism is not optimized, but that's the least of her worries. Maybe she has AKI. She skirted right past a severe rhabdomyolysis, I think, and she has a complex pacemaker history also, which we are not talking about here. But here she presents with a relatively acute L3-4 shear fracture that happened between an upper and a lower rod system. So these are not rod fractures. These are put in separately through the benefits of MIS. Any thoughts? Do you see these kind of stack-on attempts to try to stay with the MIS principles?
Yeah, it's kind of death by 1,000 cuts, and you're just putting covering your eyes as to what the major problem is, and it could be something potentially catastrophic. And thankfully, she doesn't really have a neurologic deficit here. It's not cord level, which is great. But yeah, this is. I was looking at the history, and I'm saying to myself, no way am I operating on this lady with all these issues. But I think with an unstable fracture, you probably have to do something. And no way am I going up with those compression fractures there. So the problem is within the construct, but somehow you have to realign her, which I don't think should be too challenging in the setting of an acute fracture, and connect everything and probably put pelvic screws in and maybe some kind of interbody work to help get a fusion at that fractured level at 3-4. But this is it's hard to imagine this lady doesn't have some kind of complication from even the best of hands from the surgery.
And just to add illustration to your prescient words, so the court of the family had assembled with several healthcare providers, part of that, and they all sat there or stood there with their arms crossed, and the miracle surgeon arrives there, and there's about, again, multiple medical problems, multiple services involved. The patient is laying in agony on her side because she's as mentally fit as she was. She literally can't be turned. She's laying obliquely on her side. That's the only remote position of comfort, but she's neurologically intact. And the family court then basically, without any smiles or any remote sense of understanding the gravity of the situation, says, how are you going to fix this? And I never knew of this patient, okay, but how are you going to fix it? It's a Saturday morning, and she'd come in on Friday night, and again, all the services worked through the night to kind of try to get her medically assessed and see what's going on. So the family court had arrived and awaited the solution. So here we are.
Yeah, the Inquisition.
Inquisition, exactly. So what did we do, Cameron? How long did we wait? What did we do?
So she, once she was optimized, cleared by cardiology, had an echocardiogram. We got to her about day 3 since her injury. She was anemic as well. She had a starting hemoglobin of about 8.1, and so she was transfused 2 units as well, taken to the OR, and underwent a T8 to pelvis with a quad rod construct. It was essentially open reduction internal fixation of that L3, L4 fracture dislocation with bilateral reduction rods. And so I believe initially a left spanning rod that was placed from L1 to L4-5 was secured with screws that were countersunk appropriately in accordance to allow for a dorsal translation reduction given that there was about a 50% vertebral body anterior slip, and then a right rod was secured up from T12 down to L5, which basically underwent exaggeration of the deformity and kind of the orthopedic fracture principles and alignments. So that was distracted, and then the left rod was compressed to help bring that fracture dislocation back into appropriate alignment. There's a rostral landing up to T8 with hooks. Ultimately, she had about a liter of blood loss, was given 4 units of red blood cells within the OR unit. It was noted that she had some chronic myonecrosis from the prior rod passages and metallosis around L3, L4. This was all collected in central cultures, which showed basically a giant cell inflammatory reaction formation, but no infection. Let's go to our thoracic.
So again, their magnitude of the surgery relative to trying to find some reasonable endpoint, and I did not have the chutzpah to go into L3-4 from posterolateral, so there was, the main worry for me was, again, she had, I forgot what it was, 4 previous surgeries, and I was astounded and shocked by the amount of myonecrosis that was there. This is just basically glass muscle down there. I don't know what her underlying sarcopenia was, but again, the previous surgeries had not been kind to her muscles, and she actually had a very large gelatinous amorphous mass, and these are her alignment films. I think we have some upright x-rays also, but she's actually been very happy. I do not claim to have a perfect, and the torticollis is long-standing. We actually have pre-op films on her, but she's a couple of weeks out now, and I must say, again, I did not go into 3-4 either laterally or from, did not dig around in there. She was, again, relatively precarious, and I was just happy to fix her in the back, and would deal with anything in the front later, maybe with the magic of Dr. Escuyan's far lateral surgical skills. But she actually very gratifyingly said she, since she woke up from that surgery, had no more back pain. My problem was, again, I wanted to get her off the table in a reasonable time, and that's a nice collage, by the way, Cameron, thank you for putting it together like that. But she verbatim has said since then, since I've had this surgery, I've had no more back pain, so that was kind of nice to hear. What to do with these very damaged soft tissues had me greatly concerned. We have a wonderful plastic surgeon in the audience with us, Dr. Gottlieb, but I thought of calling him in, I think, on a Sunday morning when we did the surgery, but I felt we'll just excise what we can and repair what we can, and so far I've gotten away with it. Any thoughts on these damaged muscles after MIS surgeries, and how high, how low to go, and whether to augment the 3-4 segment from the front?
Yeah, brutal. So great results. I mean, incredibly sick and old patient. The nice thing about MIS surgery is usually the posterolateral gutters are pristine. So hopefully I'm sure you packed a ton of bone in from at the fracture level, and hopefully that'll be enough in this 83-year-old. You know, I would think, when I think about soft tissues, I think of the UIV. Because I'm just holding my breath at 6 weeks and 3 months from deformity to make sure there's no PJK or PJF. And hopefully that's where I think about it the most. And of wound healing down low. But you got her out of trouble. There's no neurologic deficit, and she didn't have catastrophic medical complication given her age. So I think it's a great result. And the alignment looks great. And I'm not even thinking about that, you know, that much in an 83-year-old with an acute fracture. It's important, but I'm not moving heaven and earth to make her perfect. And
rostral fixation, do you do soft landings? Do you do rubber bands, whatever, Mercilin tape, voodoo, any tricks, tips? We use downgoing hooks a lot, so
yeah.
Thoughts?
I use screws at the UIV, and I try and get them to go down, going more anatomic. I like usually my screws straight forward, but I like the top ones to go down, because we've shown that if the screws are straight or even upgoing, that's a risk factor for PJK. And I'll use some tethers oftentimes at the top levels.
So Rod, at 3-4, there's a previous cage in there, a previous peak cage. I have not asked you yet, but if push came to shove, would you be comfortable to come in from the left side? The previous approach was actually done from the right side at 3-4.
Yeah, I mean, I've done it before, but I think, in this case, I think, it looks like there maybe was a fusion at 3-4.
There was a 3-4 peak cage in there. Would you be comfortable reaming that out, drilling that out?
I mean, if you don't have to, but I think in this case,
leave it.
I would leave it. I wouldn't go back in.
Yeah. Good. All right. We have one final case. Thank you, Dr. Hogsett. And we have Colin Gold from the University of Iowa, a neurosurgical colleague from there. And he has a case that I'm not familiar with right now, but it's something that we also deal with a lot here in the greater Pacific Northwest. And that is the wonderful subject of spondylodiscitis. I'm sure, Dr. Zuckerman, you don't see this, but this is a daily plight of ours. And we, in fact, have a patient waiting downstairs for surgery later today.
So this is a mid-30s-year-old man who presented to the emergency department with a few weeks of low back pain, denies any leg pain, weakness, numbness, bowel or bladder, incontinence. Social history: patient is currently homeless and does endorse IV drug use with fentanyl and meth in the past. Here's his physical exam. Essentially, patient's neurologically intact, no hyperreflexia. And then here's some lab data. White blood cell count was normal. CRP was elevated at 11.9. He had blood cultures at the outside emergency department that showed gram-positive cocci and clusters, which by the time he was transferred here, it was blood-borne MRSA. And here is his CT scan.
So this is a ever-vexing problem for us. I don't know how it is with you at Vanderbilt and in the great state of Tennessee, but we obviously have a very large afflicted population here with multi-drug problems and no steady homestead. And this man's BMI is what, Colin? Do you know roughly?
He's like maybe 24. He's thin.
Okay. Then. And obviously you did a C-spine and a T-spine screen, and there's nothing else brewing anywhere else?
Oh, no, he has lots else.
Oh,
brewing.
okay.
Yeah.
All right.
So yeah, here's the T-spine. So this, the affected level here is T7, T8. And then the C-spine as well. And this one is, I think, C6, C7.
So there's a lot percolating. Again, I don't know the patient, I apologize. We have about 6 minutes left, so we have to kind of get forward. So where was the crisis point? What's the main focus? I think it's the upper lumbar spine.
The main focus here was L1, L2. It looks like he had a chronic L5S1 discitis as well. And then I'll just quickly go through these other MRI sequences. So this shows the L1, L2 lesion with the active infection. He also has a psoas abscess on the right side. And then just to show these quickly, this is his MRI C-spine. This is a more chronic, I believe it's C6, C7, and then the T7, T8 is more active, but no neurology from that level. And then this is his site score of 7, which is in the severe level, which indicates surgery.
So, Dr. Zuckerman, this is an everyday problem. How's that in Nashville? How's it in Tennessee? Do you see a lot of these osteodyskitis patients with significant and dire social circumstances?
Yeah, same. That was my Labor Day weekend. It was a couple of these similar cases. And, you know, I've learned a couple pearls here, especially for the fellows and trainees. Oftentimes, especially late stages osteo, it's always 2 levels. It looks like 1 level, but it's always 2 levels. This is easy to see because it's relatively early, but they can collapse and look like 1. But I try and avoid operating in the acute infection because nothing good in active osteomyelitis, as long as there's no neurologic deficit and my hand is not absolutely forced with either a nerve deficit, mechanical instability, or horrific pain to where they can't ambulate, I try and put them in a brace, let them cool off with antibiotics for at least, as long as I can, a couple of weeks or a couple of months, and then come back and treat the deformity and treat the problem. But for this level, if your hand isn't forced, let them cool off. But this looks like to me some kind of lower thoracic to L4 fusion. And this is good that it's early because it's not an end stage osteo, which is a year or 2 later where you're kyphotic and you have a deformity to treat. So I'd probably let them cool off and then do some kind of stabilization and decompress that level. And I would probably avoid the other levels because I don't think they're causing problems.
So you just focus on that main problem zone at L1, 2, and leave L5S1 alone, leave the mid-thoracic spine, right column, mid-thoracic spine, and then multi-level cervical disease.
T7, T8, C6, C7, L1, L2, and L5S1.
Yeah. So, but we'd focus on that problem first, and this patient is in pretty severe, I think I remember now, he was in pretty dire straits there. He was not happy.
He can walk, but barely, not very far.
Yeah, so your hand might be forced to have to do something. And I've also learned you're tempted to go small because they're sick patients. You want to do less, but oftentimes a LAMI alone, which I wouldn't do here, but some that's tempting to do that, I think you go big because most of these that I've tried to do small, I've had to reoperate on.
So let's see what you did, Colin, in interest of time.
So we did a partial corpectomy, I guess you could kind of call it a TLIF at L1, L2 with a little bit of removal of the pedicle, IND of the disc space in the psoas abscess, and then posterior fusion, sorry, that's missed typo, T12 to L4. Here's the CT scan. We used a 17 millimeter height peak banana cage with BMP.
Yeah, looks great.
So relatively short fixation, relative speaking, 2 levels above, 2 below, and leaving the L5S1 early brewing discitis alone. And the biomaterial of peak and infections, any thoughts on that, Dr. Zuckerman?
Yeah, I try and use titanium. I've gravitated away from peak for a variety of reasons, but usually titanium. And sometimes if the posterior elements are completely separate from the infection, I'll stage it and do a bunch of posterior work. And then if it's amenable, go from lateral to not allow the infection up front to communicate with the implants posteriorly. But I think this is a great option if you can get down there. Just pack a bunch of bone in, maybe a cage. I usually put cages in, but sometimes if you just put a ton of bone graft in there, and BMP in the setting of infection, and I do it, and usually these will fuse, hopefully, and he's 30 years old, so he's got good bone quality. But a lot of these older IV drug users and stuff, it's a bad situation because their bone quality is horrible too.
Were you in on that surgery, Colin?
Yeah.
How was the bone quality?
His bone quality was really good, except in the disc space. Then there was nothing. It just felt like mush.
Do you feel that you got a good buttress on the remaining bone where the cage could find a good implant nest, more or less, a healthy bone?
Yeah, we did. And then we compressed as well around that to kind of hold it all together. So I felt like the cage was solid by the end.
How'd the patient do?
Initially, his pain was worse just from having a big surgery, but he's now ambulatory, so overall better.
Is he braced for the other areas? Is he in a TLSO, in a neck collar, or just watch that?
No neck collar, because that one was chronic, and I don't believe, no TLSO either.
Okay. Yeah, so this is an ever-vexing problem for us. How do you wash this out? Is there any tricks that you can share with the public?
Yeah, so we used a long irrigation tube shaft, I don't know what you'd call it. It's a metal device that we put in the disc space and would irrigate out through that. Also used a Murphy ball probe to reach kind of laterally into the psoas through the disc space to help irrigate that out as well. And you can't really see it so well on the post-op CT, but it does appear that the psoas abscess is at least smaller.
Good. Any other thoughts on this, Dr. Zuckerman?
No, I think I like the idea of anterior column support too, especially if you're going smaller in the back. I think you're asking for a DJK without some kind of anterior support. So I think it's great.
Well, thank you, Colin.
Thank you.
Appreciate all the fellows' talks. And it is my honor to introduce our guest speaker today, Dr. Zuckerman from Vanderbilt. And I'm speaking in my official capacity, thank you, Dr. Randy Davis, as Dinosaur, who sounds like John Kostrick. I got this in the chat box, so I'm proud to be a dinosaur sometimes. But speaking to the next generation, we have a leader of our next generation here today in Dr. Zuckerman. He got his bachelor's degree at Cornell, and where he graduated with magna cum laude, and he then did his medical school at Vanderbilt, where he was class president, and he then did his neurosurgery residency at Vanderbilt as well. He did a number of fellowships, one in spinal oncology at MD Anderson, and a Mayo Clinic peripheral nerve fellowship. And then he was the Cornell University Global Neurosurgery Fellow in Tanzania, where he saw a lot of deformities and really challenging cases. And did a very cool spine trauma protocol implementation that to the present date, I know that from a different friend, has been around. Dr. Zuckerman in his career has already garnered a number of national recognitions. What struck me most was that he won the Charles Kuhn Scholarship Award. Charles was a former fellow of ours at UW and was a very special colleague. And he's had numerous teaching awards and Honor Society affiliations. He's also an NFL neurotrauma consultant, and here goes my pager. And he also serves with ongoing distinction with our U.S. Navy Reserve. So it's wonderful to have one of our clear future leaders in the field of spine surgery and neurosurgery with us today. And he's picked a topic that is really problematic and difficult for all of us to kind of sort out, and that is the coronal imbalance of the spine and what we as surgeons can do to prevent it and treat it. Dr. Zuckerman, it's an honor and pleasure to have you here today, and looking forward to your presentation.
Thank you. Thank you very much, Jens, for the kind introduction. I really do appreciate the opportunity to be here. I mean, I've been watching your content for probably over a decade now, and it's really impressive, the educational advancements we've made from all your work, really. So slides seeing okay?
Yes, perfect.
Okay, great. So today we'll talk about coronal alignment, the unsung hero of adult spinal deformity surgery. These are disclosures of some work with the NFL and Medtronic. But my objective today is to impart an understanding of how we discuss coronal alignment, why it's important in ASD surgery, and how to assess, correct it intraoperatively. And every talk has a specific audience. And the audience for this is really mostly trainees, residents, fellows, and mid-level providers. Second is probably adult deformity surgeons, and really all spine surgeons, I think, could benefit from some of these topics. So we'll talk about the problem of coronal malalignment, get into some definitions, classification, literature, and then intraoperative assessment and kickstand rod, and as always, try and learn through cases. So first, discussing the problem of coronal malalignment. When we think about deformity, it's mostly two planes, the sagittal and coronal. And the content and the educational material on sagittal is everywhere. You have some of the leaders, giants, masters in our field, and everyone's talking about sagittal alignment, and relatively coronal alignment gets a lot less love and a lot less attention. There are some great talks out there, as you see here, but sagittal gets all the attention. And some of our esteemed leaders in the field have said, what's so hard? You just put the head over the pelvis. Sagittal is much more complicated. Apex, Russelli, gap, age-adjusted, etc. But it's pretty simple, and I would agree. I mean, it is simple. Put the head over the pelvis. But I'm always thinking in terms of sports analogy, and I would analogize this to golf. Right? I mean, golf, it doesn't get much simpler in terms of sports. I mean, the ball isn't even moving. But most of us, while we're playing, share a couple of different four-letter words with how challenging it can be. And rates of postoperative coronal malalignment are very high. And look at, these are 4 papers here, 20% and 67% of the Q type C patients can be coronally malaligned, 40%, 30%. So if we're talking about a third of patients leave the OR with coronal malalignment, I would argue this is a pretty significant problem. And so my title, the unsung hero, the definition is one who does great deeds but receives no recognition, not noticed or praised for their hard work. And that's what I would argue is coronal malalignment in the overall what we talk about from adult deformity. And given this presence of Seattle here and me being a sports fan, I like to compare everything to sports. So if we think about the Seattle Mariners, who represents sagittal alignment? If I'm thinking when I was growing up, no doubt Ken Griffey. But who gets less credit but is integral to their success? I'm thinking of guys like Edgar Martinez, Jay Buhner, and Joey Cora, who is a Vanderbilt alum. The Seattle Supersonics, I'm not even sure the fellows remember this team. At least some of our residents don't. But who's sagittal here? Any guesses? Who would you say is sagittal for the Supersonics back in the day?
Jackson.
Rod, what do you think?
Kemp.
Yeah, there you go. Sean Kemp, Gary Payton, trash talking. Coronal, the unsung hero of the Sonics, was this guy, Detlef Schrempf, a journeyman, good defender, and was a real glue guy for the team. And then the Seahawks football, Russell Wilson, married to a superstar, gets all the credit, but the guy doing all the hard work at the line of scrimmage was Marshawn Lynch. So coronal alignment in ASD surgery, less researched. And he says, you see here, there's about a third less published on coronal alignment as there is a sagittal. It may be simpler, but the execution is very hard. It often leads to more invasive surgery, higher risk for complications and rod fractures, and it can be really challenging to evaluate intraoperatively. And also, if you think about all, the T in technology, all the tools for us as surgeons, patient-specific rods, it's all in the sagittal plane. So we have a lot of help and a lot of assistance in the sagittal plane, but a lot less for coronally. And then what about compensatory measures? As everyone ages, we all become kyphotic, especially in the upper thoracic spine. Yet most people walking around the world don't need deformity surgery because you have all these different compensatory maneuvers between the cervical spine, thoracic, hyperextending, and then the lower extremities. Coronally, there's a lot less compensation mechanisms available. Asymmetric hip and knee flexion is really the only one that can be very uncomfortable, lead to falls, and it doesn't go away with sitting. Sagittal malalignment is gone. Patients can sit and be comfortable, whereas coronally, it's still there. And as you get older, we sit about 30% of our lives in half the day. So deformity that's present while we're sitting is still a major problem. So that's the problem of coronal malalignment. And now let's get into some of the meat here of how we talk about it and some of the literature. So we'll go over regional alignment, global alignment, and then talk about pelvic obliquity, leg length discrepancy, and then some of the relevant literature. So this is a great paper put out by Dr. Lenke and James Lin that thought about reclassifying adult idiopathic scoliosis, and they used 3 areas. The main adolescent idiopathic classification made famous by Lenke, type 1 to 6, and then they added a lumbosacral modifier, the fractional curve. The lumbosacral fractional curve is critical in adult deformity surgery, and then a global alignment. And this is how I talk about the spine, and I encourage, especially neurosurgery residents who don't have as much experience with AIS classification, the proximal thoracic, T3 to 5, main thoracic, 6 to T11, 12, thoracolumbar / lumbar really stops at L4, and then the lumbosacral fractional curve. And I'm very intentional with the language I use because the word fractional curve is confusing. Fractional doesn't tell what we're talking about, but I say lumbosacral fractional curve because that's what we're talking about, L4 to S1 often, or 5 or 3. And that's where patients are often symptomatic from their radiculopathy. The L4 and L5 nerve roots are much more sensitive than L1, L2, or L3, and we have to address the neurologic deficit or the pain in these patients. So this is a patient, you could tell, this is a 49-year-old female who's about 2 years out I treated. She's a type 6 for a major thoracolumbar / lumbar curve. She's got combined malalignment. But you can look at the x-rays and already tell where her leg pain is going to be. It's not going to be on the right side where her major curve is. It's going to be down here at the concavity of the lumbosacral fractional curve. So sure enough, she had left leg pain. That was resolved as we corrected the deformity. So sure, we're correcting everything globally, sagittal plane, coronal plane, but paying attention to this fractional curve, trying our best to horizontalize it and treat the neurologic deficit or the radiculopathy is critical. And this is some of the cases that the fellows did such a great job of presenting. There's an intersection between some of these smaller surgeries and what ends up being a deformity. So the fractional curve is critical in short segment fusions. Their patients are often symptomatic there. And I think incorporating some of these deformity principles into degenerative surgery with respect to coronal alignment is really helpful. We're already doing this with sagittal alignment. Everyone's now harping on L4 to S1 should be around 35 to 40 degrees, but there's no reason we shouldn't think about coronal alignment in some of these 1 or 2 level fusions, especially because patients are most symptomatic there. So this is a 73-year-old lady with left hip pain. And again, look at the x-ray, you can tell. These are all PA films. So this is the left side. The concavity of her lumbosacral fractional curve is here. So she's got an L5 radiculopathy. She has a pacemaker. She's got a mild scoliosis. This patient doesn't need a big spinal reconstruction. They just need a short segment fusion. So we did a 5-1 T-lift. And as I'm doing the T-lift, I'm doing PCOs, I'm doing bilateral disc access, and I'm trying my best to horizontalize the level that we're fusing. It's just a 1-level fusion, but I'm thinking down the line for her. So we take we don't make it perfect. We don't need heroic measures here, but improving the fractional curve by about 10 degrees hopefully will help her avoid more surgery down in the future. And these are various patients, some I've operated on, some we're optimizing, who all have major spinal deformities that originated from their lumbosacral fractional curve being fused in the wrong direction. These are major problems, and they're fused. So there's really little compensatory mechanism available. This is an interesting patient that I wasn't sure how it was going to turn out. 71-year-old female. She was actually a college professor, a public speaking professor, treated with a prior L4 to S1 fusion. She had her implants taken out at 5 to 1, but she's fused from 4 to 1 with major curve in the thoracolumbar spine. She's almost lordotic in her thoracic spine, leaning very far forward with a major curve. We got her off her pain pump, took her spinal cord stimulator out, and I'm thinking to myself, if I need a kickstand rod, it'll probably be on the right side because this curve's going to be stiff. But sure enough, it was the opposite. And the fractional curve really didn't move here. So as you see, we realigned her nicely. We went up to T2, and she's actually leaning a little bit to the left side. Luckily, it's within the 3 centimeter threshold that we have. But this fractional curve is fused and it didn't move, and that made her spine take off a little bit to the left side. So we actually almost maybe could have thought about a kickstand rod on the left side. And I will say, 4-to-1 was fused. I didn't think she was a candidate for a 3-column osteotomy. She's probably a little under sagittally corrected here on the sagittal plane, but thankfully she's happy and hasn't needed any reoperations, but just to self-critique a little bit there. And this is what we're trying to study in our lab. These are all my great partners at Vanderbilt. We have a combined orthopedic, neurosurgery, spine outcomes lab. As you guys, I'm a very staunch believer in combined training and everyone working together because patient care is better and research is better. This is a study that we'll be presenting this year. Hasn't been published yet. We're looking at ASD patients who have preoperative coronal malalignment. 2/3 of them had some kind of fractional curve fusion, and most of them, all of them did, but 2/3 had a fractional curve greater than 5 degrees. And those were the prior lumbar fusion we showed had less fractional curve correction, but they had a more correction of their major Cobb angle because that wasn't fused and it was easier to correct. And as we'll see, this can really predispose patients to malalignment. So now going from regionally to globally, CVA is a term I like to use. Oftentimes you'll see patients put the CSVL, the central sacrovertical line, and say CSVL equals 5 centimeters. But if you think about it, that's just a line. The CVA is the difference between the C7 plumb line and the CSVL. So I try, and it's a nice corollary to SVA, sagittal vertical axis, coronal vertical axis. So I'm a real proponent of trying to use the right language because the better language that we use as attendings is easier for our trainees to understand. So CVA is the measure for global alignment. And we've shown that just like taking sagittal alignment to the head at the EAC, same thing for coronal. We published this paper looking at the orbital CVA. The medial orbits at our skull base are very hard cortical bone, and you can often find the medial edge. The odontoid can be very hard to find, especially with dentition, and C7 really doesn't take into account the cervical spine. So this orbital line can be a nice way to take coronal alignment up to the head. And we showed that if you have a higher orbital CVA, increased complications. And if there's a difference between your orbital CVA and your C7 CSVL or your C7 CVA, that's a risk factor for reoperation as well. And you can see a lot of different settings of scoliosis. This line is repeatable and easy to find those medial orbits because of the very hard bone and hard cortical edges. I think if you remember one classification from this entire talk, this is it. Some people refer to the Bow classification, but Chu is the senior author. So the Chu classification of 3 different types of coronal malalignment. Type A is a CVA of less than 3 centimeters. Type B is greater than 3 centimeters, and your head is towards the concavity of the main curve. And type C is the ones we worry about the most, where your head is towards the convexity of the main curve. And this is a beautiful classification. I love it because it's has all the things you want in a classification. It's elegant, it's simple, and it's intuitive, and there's not a lot of things to remember. But I will say there are some things that I think that you can improve here. How do we define the major curve? If your fractional curve is 30 degrees and your major curve is around 30 degrees, which one is the major curve? That can be challenging. And then type A's can, being less than 3 centimeters, we're kind of tuned to these aren't the ones to worry about, but type A's are the ones to worry about, even in some ways the most, because you can take someone aligned and make their alignment worse if you're not paying attention to the fractional curve. I have to mention here from the ESSG OBE classification, which is just a similar variation. This actually has a treatment algorithm for what to do. It's a little more cumbersome, but it's the same principle as OBE type 1 is a Chu B, OBE type 2 is a Chu C. And they've done a lot of work here looking at thresholds. And they're advocating for a 2 centimeter threshold, which is narrower than the 3 centimeters. And they've started to show that maybe that's where some of our malalignment problems start. But remains to be seen. We need more research. And then talking about some of these terms that get thrown around, but I think we probably don't have the best understanding of them. Pelvic obliquity, any misalignment of the pelvis caused by either a leg length discrepancy or scoliosis. So when I think of pelvic obliquity, is it coming from the spine or is it coming from the lower extremities? But it's confusing. There are papers that measure as an angle. There are papers that measure as a distance. And some people draw a line across the iliac crest. Some people, which I advocate for, is drawing a line from the bilateral acetabuli because I think it's more reliable and easier to see. But another confusing area that we probably should do much more research about as we think about coronal alignment. Then leg length discrepancy. We don't have an EOS here. We're working on it, but that's really the only way to tell if there's a true leg length discrepancy. Most of orthopedic literature says a threshold of 2 centimeters. It can be caused by a variety of different settings, but knowing where the hips are, whether it's from the spine or the lower extremities, is critical in aligning someone coronally. Now, before we get into the intraoperative section, we'll go over some key points from the literature because there is, especially in the last 5 years, there's a lot more literature out here on coronal alignment. So I think some key points: people are not happy being coronally malaligned. Sagittally, I would agree, is worse. Probably people are more symptomatic from sagittal malalignment, but coronal malalignment is just as important. We do not have a threshold to establish coronal malalignment, which makes it very hard to study. Coronal malalignment, we've shown, can lead to more challenging and invasive surgery. And there are a lot of known risk factors now that we know that can put us at risk for coronal malalignment. This is a study we worked on in fellowship at Columbia, 4 different categories: neutral alignment, coronal malalignment only, sagittal malalignment only, and combined coronal and sagittal. And we show that as you add coronal malalignment on top of sagittal, patients are much worse. Their ODI increases by almost 10 points. And then what's our threshold? CHU classification uses 3 centimeters. ISSG papers use 3, but some use 2 and some use 4. So it's hard to study something when we have a moving target, like the bottom right-hand picture. But I think overall, 3 centimeters is probably the best threshold to use. And this is another study that we worked at, hasn't been published yet, but trying to use our continuous data to find out what the best threshold here. This figure right here is looking at a Uden's index or J statistic of predicting patients with an ODI greater than 40. This is an SRS pain and function less than 6. And you see this number hovers around 3 to 4. So I think 3 is probably the empiric way to classify this. Another study we worked on looking at surgical invasiveness of coronal deformity. And the story is told right here. I really like these graphs. So on the x-axis, we have preoperative, we have CVA right here. And on the bottom graphs, we have SVA. And we have EBL and operative time across here, EBL and operative time. And you can see it's a much stronger relationship between CVA and blood loss, and the beta value is higher for coronal malalignment, coronal CVA rather than SVA. So I think this makes surgery a lot harder. Then risk factors for coronal malalignment, we found in this study, your overall CVA, pelvic obliquity, and then both QB and QC curves. And interesting, SVA, underline that, because if we're hyper-focused on the SVA, sometimes we can ignore the coronal plane. So even a high SVA can make us ignore or not pay as much attention to coronal malalignment. These are various studies just showing basically the same thing. Those QC curves, where L4 and 5 remain tilted, are the biggest risk factors for us throwing people off, is undercorrection of the fractional curve. And then iatrogenic CM, this is something like we talked about, the CHU-A's. This is a study, 153 patients, 9%, so 1 in 10, had some kind of iatrogenic coronal malalignment. And these were the risk factors here. So this is probably the worst part. And I think patients are a lot less tolerant. I think a patient who is very coronal malaligned, who we take to 4 or 5, a little undercorrected centimeters, will tolerate that much better than a patient who we curate an iatrogenic coronal malalignment. And maybe they'll be less tolerant of a 2 or 3 centimeters if they were perfect before. All right, in closing now, we'll talk about some of the intraoperative assessments to assess coronal malalignment and the kickstand rod. So operative techniques to correct coronal malalignment, we touched on it in some of the fellow presentations. But I think the workhorse of deformity surgery, especially in the non-fused spine, is PCOs, posterior column osteotomies at the apex. And with some good carpentry, some compression distraction, you can usually correct most of the scoliosis or most of the curves that we have. And then if I'm thinking about the fractional curve, we're thinking T-lifts or A-lift. And this is just a picture from some of the techniques I use. Wide T-lifts with screw-based retractors on the ipsilateral side and contralateral distraction on the other side. And this disc jack can be very helpful too. It's very powerful, and you can really distract on the concavity extensively and make a really big hole. So do a good deformity T-lift and get a big graft in there. To Dr. Chapman's point, get a lot of bone graft as well. And then in more severe forms in the fused spine, we can think about an asymmetric 3-column osteotomy, which is definitely, technically challenging. But in the reality, most of the work in an asymmetric PSO is on the convexity, because that pedicle is sticking up out of you, and it becomes mostly a glorified transpedicular decompression. Oftentimes, you don't have to do much work on the concavity of a curve. So it's, again, still technically demanding, but most of the work is taking down the pedicle on the convexity, decancellating the body, making sure the roots are free. And you don't have to do much on the concavity because you're going to be expanding that level, and you're not going to be as prone to crunching down that nerve root. And then a kickstand rod, which we'll go over. But I would argue that even in the best tools, technique, carpentry, we need to know where we are globally, and that can be challenging. So how do we determine intraoperative coronal alignment? And it's been, if it's a shorter case, 4, longer cases, 6 or 8 hours. We're tired. We've been doing a lot of work. Case is almost done. What to do next? I think it's tempting and probably not the best thing to just look in the wound and say, okay, looks straight. I would argue we're not at our best at hour 6 or 8 after a case. And also, we don't know where the hips are, which is critical. The other method, if you don't have a long cassette in the OR, is a T-bar, which can be really helpful. But even then, there's some disagreement on where to put your bar to assess where the pelvis is. And then probably the gold standard is the intraop long cassette. But I think the T-bar and the long cassette x-rays are the most useful. And it's just a shout out to my co-fellow, good friend Alex Ha, who put this paper together that looked at the central sacral pelvic line, which is basically intraoperatively accounting where the hips are with a line across the bilateral acetabulae, a 90-degree line up, and seeing where C7 rests in relation to that. And that will help you account for where the pelvis is and where the patient's going to stand after. So how do we do this in the OR? These are my 3 simple steps to determine intraoperative coronal alignment. First, critical to know where the pelvis is, as we said, and I use the bilateral acetabuli as my marker because the iliac crest, again, can be hard to see. Bilateral acetabuli is always reliable. Long cassette x-rays or a T-bar. Once you do that, then you have to compare intraoperative x-rays to their standing scoliosis x-rays because everyone stands a little different, whether it's pelvic obliquity from the scoliosis or leg length discrepancy. You have to see how they're going to stand when you get them off the table. And then comparing where your intraop acetabuli are to your preoperative standing acetabuli and account for how that's going to change on the table. So let's see how this is going to work. This is a 64-year-old gentleman I've treated. Previous laminotomy, degenerative scoliosis. And this is one of those 2A curves that we're worried about throwing off. So he's got about a 50-degree thoracolumbar curve. He's got a 25-degree fractional curve and left leg pain. This is a 2A. He's well aligned now, but I'm worried about under-correcting the fractional curve, correcting the thoracolumbar, the lumbar curve, and throwing him off to the left side. So this is our case. We've done our T10 to pelvis with three T-lifts, and this is our intraop x-ray. And I look at it first and say, looks okay. I think I'm happy with that. But the more I look at it, I say, all right, where are the acetabuli? So that's where they are right there. And we compare them to pre-op. So intraoperatively, he's a little off to the left. And intraoperatively, his acetabuli, the right side is a little higher. But preoperatively, he's got a little bit of a leg length discrepancy. Preoperatively, his right acetabuli is higher than how we're looking at him in the OR. So when he stands, that right side's going to go higher, and his head is going to be more over to the left. So that prompted me to put in a kickstand rod to make sure he's well aligned. And if we didn't, I feared that he would have been off iatrogenically worse more to the left side. And you can see he's well aligned globally to near 0 CVA. So kickstand rod, when to do it, all the risk factors we talked about, fixed coronal malalignment, 2C or 2A curves. And I put this point in here, level of difficulty, because I don't think it's that challenging. I'm not going to say it's easy because very few things we do are easy, but compared to some of the other things we do, it's really not that challenging. And it's a tool that I think most surgeons should have in their armamentarium to correct coronal malalignment. So we put this paper together, just simplifying it, making a very simple 8-step process in how to do this. And this is the case from the paper that we looked at. Patient with, this is actually mostly a sagittal problem. She had PJF from an outside surgery and was having neurologic symptoms. So we had to correct this, but she's already, because of that fractional curve, she's already leaning to the right. And if you tease out on her history, she says, yeah, at the end of the day, I do feel like I'm leaning more to the right. So, and if we take her to the upper thoracic spine, we know she's going to be a lot less tolerant of that coronal malalignment. And this is from this great ISSG paper that says if you go to the upper thoracic, patients really are much less tolerant of coronal malalignment. So just going through the steps, the first step here is to place kickstand screw. And the way that we do this is it's right around the level of the L5 or S1 screw. And I just clear off, expose some of that anterior ilium, and then I'll point the screw right at where I think the tip is of my usual S2AI screw. And you can do this with navigation. We do it freehand, and it's pretty reliable. But as long as you are pointing towards the tip of your pelvic screw, you're usually pretty good. Then place the contralateral main rod and lock this down because you don't want to lose your sagittal correction. So lock down the contralateral rod and keep it tight from top to bottom. Then you place your ipsilateral main rod, and it's important to leave this long distally because as you distract and kickstand them over, you're going to lose rod here. So you want to have extra rod caudally. Then you place a domino in the lower mid-thoracic spine where you want to hook in. Then you place your kickstand rod. And just like we left our main rod long distally, we're going to leave our kickstand rod long proximally so we don't lose rod as we distract. And then I lock all the set screws above the domino. We loosen all the set screws below the domino because, again, we're going to lose rod down here caudally. And then we loosen, as we said, loosen these set screws, and then we take our rod gripper and we distract, and it's quite powerful. And this is kind of what it looks like intraoperatively. As you can see, losing rod right there. As we distract, we'll do a couple more clicks. We'll tighten there and then assess our alignment after that. So this is what we got intraoperatively. And I said, after a couple of rounds of distraction, I said, oh, man, we overcorrected her. This is not great. She's going to be leaning to the left. We're going to have to take some of this out. But then I went through our usual steps and compared how she stands preoperatively. Preoperatively, her left acetabuli is higher. Intraoperatively, her right acetabulum is higher. So how she is on the table is not how she's going to stand postoperatively. So this said, you know what, as she stands, her right side is going to go down. Her head is probably going to be over. And sure enough, we were able to align her well postoperatively just by leaving it. Even though intraoperatively, we could have easily been tricked by thinking that we were pushing off for the left. So again, speaks to the value of comparing pre-op. And you can see I was nervous to lose rod here. So I left the rod a little long here and long down here because I didn't want to have to lose rod and compromise our correction. So in the last 5 minutes here, I'll close with a frustrating kickstand rod case where that kind of threw me for a loop that I wasn't expecting. I referenced to Happy Gilmore that a lot of our residents have not even seen this movie now, unfortunately.
Yeah.
Wow. So this is a 29-year-old female, back and left leg pain. She had a prior fusion, a 12-year-old, and she's decompensating distally. And also her screws are pulling out. And she's got some kind of presumed pseudoarthrosis or implant failure distally. So she needs to be realigned in both the sagittal and coronal plane. So I'm talking about this case with our residents. We have a very detailed plan. I asked them to come up with a plan before, and we see how our plans match up. So she's well balanced now. This is one of our residents, Soren Janssen, phenomenal resident. And I say, so Soren, we're probably going to need a kickstand rod here. What side do you think? He says, I think we're going to need a kickstand rod on the right side. And I immediately, probably barely let him even finish his sentence, said, incorrect, we need a kickstand on the left, and then lectured him for another 5 minutes because that's kind of what attendings do. And he just kind of politely nodded his head. So we get in the case, and this is how our pre-op acetabuli are. So how you comparing standing to supine preoperatively can give you an idea for how they're going to be on the table. So this is our intraop x-ray. So we did our left kickstand rod, which is what I said, and sure enough, whatever Soren said, he had some validity to it because it looks like we certainly pushed her over to the right side. So I'm saying to myself, how did this happen? I don't understand. She had a solid fusion. Her fractional curve is off to the left. We've made her worse. This is her preoperatively. But if you look closely, what I missed is that the LIV, the last segment here, L23, is fused with about 23 degrees of scoliosis. So really harping on that preoperative imaging, she's got a 25-degree scoliosis here, and that's how she was fused. And you can see this is the coronal CT and sagittal CT. She's solidly fused there. So we corrected the fractional curve, but this was fused. So we weren't able to correct that. So we threw her off to the other side. And intraoperatively, compare her acetabuli. She's standing preoperatively, she's fairly even. The right side's a little higher, but intraoperatively, the right side's even more higher. So when she stands, her right side's going to go down, and her head is going to go even more to the right. So this prompted us to pull an audible at the last second and put a kickstand rod on the right side, take out some more of distraction on the left, put this off on the right. She's still not perfect, and we actually made it a touch worse, just by about 4 millimeters, but still she's well aligned from her, according to the 3 centimeter threshold, and thankfully feels like she's standing up straight. So I think we're close to on time with 2 minutes left. I really appreciate the invitation. Hopefully I proved to you that coronal alignment really matters. It doesn't get nearly as much attention, but it's integral to what we do. Watch out for the CHU-C, especially the CHU-A curves. The kickstand rod is something that's a really useful tool and important intraoperatively to compare how people stand. So thank you very much for your time, and please reach out anytime with questions.
Scott, that was absolutely fabulous. That's an instructional course, lecture or session in any of our major national meetings in itself, just a treasure of values. So I really loved the technical detail that you shared with the kickstand rod. Here's my question about coronal imbalance and leg length discrepancy. And I, again, want to highlight how cool it was for your neurosurgical colleague to educate us in the orthopedic community about valuable insights, looking at the hips first. I will now actually, and I'm going to put that on my agenda for clinic today, use the acetabular line and not the iliac crest line. I must confess, I did not do that. I will change my practice based on my lecture. Here's my question to you. Leg length discrepancy is a feared problem with deformity surgery because patients are kind of habituated to a certain way of balancing or imbalancing themselves. and then we do a nice deformity surgery correction, and they're out of line and unhappy with that. How much do you use for your deformity x-rays, kind of standing blocks first to see how they equilibrate? How much do you use shoe lifts for patients prior to surgery to see how they can kind of rebalance their spine, their leg length inequality within reason? I'm not talking about some extreme leg length discrepancy, but like within 2 inches, I think was the number that you mentioned.
Yeah, I mean, I can think on one hand, it's rare, but there are some patients, especially older patients, you don't want to do a big surgery on. Give them a shoe lift and they're happy. I think most younger patients probably don't want to deal with the shoe lift. But that last patient I showed actually had a shoe lift already on her own. But yeah, you're right. It's confusing. I mean, we used to ask in fellowship, we used to ask Dr. Lenke this all the time. How do you know what their legs are going to do? And he would say one simple thing. He would say, they stand how they're going to stand. And we were like, and he would just say, they stand how they're going to stand. And I think that speaks to comparing however they stood before surgery is probably how they're going to go back to after surgery. But I do think you're right. People, so sometimes this isn't the paper I put in, but we looked at immediate post-op x-rays to 2-year x-rays. And does coronal malalignment change? And we found that 50% of patients changed their CVA by at least 1 centimeter, even if you're fused to the sacrum, an instrument of the pelvis. And the good news here, of those 50%, 2/3 improved. So patients, after you've done a major reconstructive surgery, they're used to standing that way for 40 years. There is some tweaking and some self-correction goes on, and usually for the better.
Curveball question. I noticed several of your patients had dorsal column stimulators and that had pretty significant deformities. I've had the same empirical, completely non-validated statistical observation. Do these DCSs throw off patients' internal equilibrium somehow, their proprioception, their body posture? I mean, this is literally an out of nowhere question, I realize, but since I saw several patients of yours and I have had the same observation for a while now, is there something to that?
Great question. I mean, I'd be lying to you if I told you I had any insight into that, but I think it's possible. But I will say I've seen some patients who just by happenstance, recommendation, whatever, the first spine provider they saw is a pain doc and not a spine surgeon, and they'll end up with a spinal cord stimulator just by luck of the draw. And makes sense. I mean, by the numbers, there are a lot more of them than spine surgeons, but definitely potentially, but it's a bad first option, I think, in patients who have a treatable problem.
So my final question, coronal imbalance, because we'll have to get going, and you're so generous to share your time and expertise with us in such a magnificent fashion. Going to the upper thoracic spine versus lower thoracic spine, coronal rebalancing in general, do we do better if we go to the upper thoracic spine to correct a serious coronal imbalance? Just as a nutshell thing, is that a fair statement? And if so, how high? Is it T2? I think you showed some T2 cases, T4 enough, etc. So just a generic upper versus lower thoracic spine, then finer points as to which level to stop at.
Yeah, great question. I mean, I don't have a compelling reason to say that if you're worried coronally, go to the upper thoracic spine. I think it just depends on where patient's scoliosis or deformity is. That would drive me to go to the upper thoracic spine. I think most of these issues are coming from the fractional lumbosacral fractional curve, whether we undercorrect it or not. So I think going to T10 or T9, it's still really powerful to correct coronal malalignment. But if there's anything driving me to go higher up, I think you can correct it the same from either upper or lower thoracic. But that decision to go to upper thoracic is probably for other reasons less than their coronal malalignment.
A finer point was, and I struggle with it all the time, patients have had previous subaxial fusion surgeries, let's say to C7, and we're thinking about going to the upper thoracic spine. Do we have to tie that in, or can we leave like 2 or 3 motion segments alone? I think you showed a patient where you left 2 or 3 motion segments alone. So I always struggle with that question.
Yeah, I mean, I think we'd sleep easier if we tied it into the fusion somehow, and because you're putting those levels at risk for PJK and right between the fusions. So, I mean, if the ACDF stop at C5, I'm not going to go to C5, but if it's something lower down, C7, T1, then maybe I would think about going to T1. Or I think in that patient, we tethered a little higher to give them a little support to bridge them to where they were already fused. But this is a little out of the box thinking too. I've thought about as PJK prevention, maybe doing, I've never done it, it's just an out of the box thinking, maybe doing ACDFs to prevent against people from failing. Like there's one lady I had to go to T1, and I'm thinking maybe a 7-1 ACDF would relatively quick operation would have been a way to prevent PJK, but no data there, just shooting from the hip. But
Well, we loved your presentation. I'm going to re-watch that later myself because there's so many cool tidbits in there. The cases were very evocative. And again, that kickstand viewing will be mandatory viewing for our fellows, just as putting the PIs in the future for their case presentations, but they were excellent otherwise. Thank you so much, Scott. Great to see you. Fantastic treasure of knowledge, really. Appreciate it. Have a great day, everybody, and thanks for joining us.